Okay, thank you everyone for your interest in varicose veins. We're going to give a little slide presentation today and talk about what causes varicose veins and then how we treat them. Varicose veins is a very common disease. It's the most common vascular disease, and it can range from anything from the small spider veins that we can see all the way up to sores and ulcers and infections in the legs and anything in between. And it can all be due to the underlying cause of varicose veins. It's very common. It affects at least 10 to 20% of Americans and almost always runs in families. Most people with bad veins will say that they can remember their mother or grandmother having terrible looking legs or bad varicose veins or never wearing shorts. So again, it tends to be genetic. And most of the time when we talk about varicose veins, people picture the big blue bulging veins like this, like we see here in this picture. And sometimes we can have people that have very bad looking legs like this and have very little pain or discomfort. And on the other end of the spectrum, there's people that don't have any visible varicose veins, but do have a lot of pain and aching and throbbing in their legs. And it can be still due to varicose veins or venous disease. So the way the legs look does not necessarily correspond with how they may feel. And as I mentioned here at the end or at the bottom, it's a progressive disease. And what that means is that it will just keep getting worse and worse over time. It's never going to go away on its own or get better on its own. The symptoms that we typically see: leg pains, cramps, heaviness, swelling, aching, throbbing. Those are very common symptoms, usually worse as the day goes on while you're on your feet all day. Typically better first thing in the morning when you first get up out of bed and your legs have been elevated all night. Another symptom is restless leg syndrome. That's a fairly more recent diagnosis that we use for people, and that's where your legs tend to jump or twitch or kind of get that I just can't sit still feeling. And we know that about 40% of the time restless leg syndrome can be due to underlying venous disease, and if we fix that vein problem, the restless leg syndrome may improve or even go away. More advanced problems are when we start seeing skin changes, and that's this yellow, brownish, yellowish, sometimes reddish rash that we get down around the lower leg and ankle area. Typically starts on the inside of the leg and then may wrap its way all the way around the ankle and then actually work its way up the leg. And once we see those skin changes, that's a sign of fairly advanced disease. When the skin changes occur, which is due to the pressure in the skin and some of the chemical reactions that the pressure in the skin causes from the venous disease, the risk for bleeding and ulcers and infections goes way up. So again, that's a sign of fairly advanced disease. When we talk about veins, we need to differentiate that from the arteries. The arteries shown here in red are the blood vessels that carry the blood out of the heart and then out to the body. Because the heart's a very strong pump, the blood in the arteries is under a lot of pressure, just like a garden hose. If you squirt a garden hose around, or if you cut your artery in your wrist, you see the pictures on TV where blood's going everywhere. That's because of the high pressure in the arteries. Because the arteries are under such high pressure, the arteries themselves need to be very strong. They're very thick, some places up to 1/4 of an inch thick to carry all that pressure. However, by the time the blood goes through the arteries and then out through all the tissues and organs and skin and muscle, and then it gets back into the veins, shown here in blue, whose job is to take the blood back to the heart, it's lost a lot of its pressure. The blood flow in the veins is very different from the arteries. The blood flow in the veins, instead of a garden hose, is more like water just trickling down a driveway. It's very slow and sluggish. So we don't see a lot of pressure in the veins normally. Because of that, the veins don't have to be very strong, and they're not. In some places, they're as thick as a piece of tissue paper, and you can see right through them. So they're very different structures than the arteries. Where the arteries might be like a lead pipe in your house, the veins are more like a water balloon, very thin and stretchy. Here we see the veins in the leg that we're most concerned about, and the veins in the leg really run in two parallel systems. Shown here in light blue are the main veins, what we call the deep veins of the leg. And those are the veins that run down inside the muscle, and their job is to carry the blood up the leg and then connect and go back up to the heart. And there's about 90% of the veins, or the blood in your legs and the veins, is down in the deep veins. So they're really the main veins of the leg. Shown here in dark blue are what we call the superficial or the skin veins. And the two main skin veins are the great saphenous vein that runs here from the groin all the way down the inside of your leg to the ankle. And then its little brother behind the knee is the small saphenous vein that comes out behind the knee and then goes down the back of your calf. So those are the two main skin veins. And even though we call them skin veins, you don't really see these two veins. They're deeper in the skin. They're down against the muscle. But all those veins in the skin that you do see eventually connect into one of these two veins, which then connect back into the deep veins to get the blood out of the skin, into the deep veins, and then back up to the heart. The way the blood gets up your leg against gravity and back to the heart is by a mechanism that's called the calf pump. As I mentioned earlier, the blood pressure in the veins is very, very low. And normally there wouldn't even be enough pressure to get the blood up your leg against gravity back to the heart. So what your body does is uses your calf muscles and the muscles in your feet and your thighs to help push that blood up the veins and then back up to the heart. You can see here the deep veins that are buried down inside the muscle. And what happens is when those deep veins, or when the muscle squeezes, the blood gets squirted up the deep veins. However, unfortunately, it also gets squirted right back down toward your foot. So to counteract that, inside the veins are these little one-way check valves which only let the blood go up your leg and not down. So the little valves keep the blood going up as the muscle is contracting. You can also see in this picture here that there's not a lot of squeezing on the skin veins. So the superficial veins are not very good at getting the blood up your leg against gravity, not like the deep veins are. This demonstrates that process again. You can see as the muscle contracts, the blood gets squirted upwards. However, as soon as the muscle relaxes, like if you're not moving and just standing still, then gravity takes over and pulls the blood backwards. It comes back down toward your leg, and then the little valve closes, and that stops the blood from leaking all the way down. The blood then sits there waiting for the next muscle contraction to push it up. The problem with varicose veins comes when those valves don't work properly. If that valve doesn't close properly, when the muscle isn't contracting and the blood starts to back up, then it will just keep going right down your leg and all the way down to your foot or ankle, or until it does hit a valve that is working and builds up pressure. As gravity pulls down on that blood, the pressure builds up. Normally there's a valve every couple of inches, and that's about how much pressure those valves in your veins are made to hold. So if all of those valves in your leg are not working, now instead of a couple, 2 or 3 inches of pressure, you maybe have 2 or 3 feet, maybe the whole length of your leg. The pressure of any column of fluid is dependent on how high that column is. So 2 or 3 feet is a lot more pressure than 2 or 3 inches. All that pressure builds up in the veins. Because the veins are very thin, they stretch. So under all of that pressure, the vein starts to stretch. And as it stretches more and more, that valve works less and less. So the pressure keeps building up, more blood. The bigger the vein gets, the more pressure builds up, etc., etc. That's why this is a progressive disease that just gets worse and worse over time as the pressure keeps building up. And the way this results then in varicose veins that we see on the surface, we show here. You can see this little picture here is a drawing of this junction up in the groin where the great saphenous, the main skin vein, is bringing all of the blood from the skin and dumping it into the deep veins. So what's happening is the deep veins are pumping the blood up your leg as the muscle squeezes, and then as that blood gets up here to the groin, where the great saphenous vein is coming in, if the valves in the great saphenous vein are not working, that blood that worked its way all the way up the deep veins now goes out into the skin, into the great saphenous vein, and gravity actually pulls it right back down toward your feet. As it's getting pulled down to your feet, it gets pulled out into the actual skin veins. Again, this is all blood under pressure from gravity, so that puts pressure in the skin veins, and that causes the skin veins then to swell, become large, become varicose veins. This whole process of the blood leaking down your legs because the valves are not working is what we call venous insufficiency. And that's really the underlying disease then that leads to varicose veins. To show here, as the pressure builds up in the actual skin then, that's where all the nerve endings are for sensation in your leg. So that's why we get the throbbing and the aching and the pain and the discomfort. And then as I showed earlier in more advanced cases, actual damage to the skin to where we get rashes, risk of ulcers, risk of infections. And that's all due to the pressure that's building up in the skin veins. As we show in this diagram here, as the pressure builds up, not only does the vein get bigger in diameter, as I showed earlier from the pressure, but the vein also stretches out in length. So it becomes longer than it's supposed to. That then results in the corkscrewed, curly-cued varicose veins that we see here. And people talk about varicose veins, which are the big bulging veins, and then spider veins, which are the small veins that we see. And people will say, well, I have varicose veins, or I just have spider veins. And people think the spider veins don't hurt and the varicose veins do. Well, really, they both come from the same underlying problem, and that there's blood leaking down this great saphenous vein. The blood then leaks out into the skin. It just depends whether this skin vein is a large vein or a small vein as to whether or not we see a bulging varicose vein or spider veins. And both of these can hurt or not hurt just as well as the other. That really depends on how much blood is building up behind it and how much pressure there is behind the vein as to how much this vein may hurt or not hurt. So the size of the vein really is not that important as how much pressure there is behind it. The way that we find the leakage in these valves is using an ultrasound, and that's really the piece of equipment that's really changed the treatment of vein disease in the last 20 or 30 years. It used to be if you came in with varicose veins, we would strip out the great saphenous vein, assuming that was probably where the leakage was, but we didn't always know for sure. With the new ultrasounds, we can see the veins, we can see the valves, we can see the blood flow, we know exactly where the leakage is, and we're able to target that directly and take care of that problem. So the ultrasound is really a key piece of equipment in treating vein disease. For a phlebologist or a vein specialist like I am, this ultrasound machine is like a stethoscope. We use it every day on every patient to look at the veins in your leg to see which ones are working, which ones are not, and then we know exactly how to target our treatment. As far as treatment, first line treatment is what we call conservative measures, and that's things like exercise, elevation, compression stockings being the main part of this. And these are all things that help put pressure in the skin or relieve the pressure in the skin veins and help the blood go up the deep veins and back up to the heart. And all of these things may work temporarily or work while you're doing it or relieve the symptoms for a short time. However, as soon as you quit doing it or quit elevating your legs or you're back on your feet for a long period of time, the symptoms all come back because the leaky valves and the leaky veins are still there. So these are really just temporizing measures that may help relieve the symptoms for a short time. When it comes down to actually eliminating the problem, that requires surgery. And we have to get rid of these leaky veins and leaky valves that are allowing the blood to leak back down into the leg. This process, the first step is to get rid of this leaking vein, which then stops the blood from getting out into the skin under gravity pulling it down. The second step then is to get rid of the actual veins in the skin that we see here. Just because we get rid of this leaky vein, this great saphenous vein here, doesn't necessarily mean that the veins in the skin are going to go away. So that's the second step. I like to equate this problem to if you had a leaky sprinkler line in your lawn. If you've got a line in your grass or in your lawn 2 feet down that's leaking, you're going to get a bunch of puddles. But if you want to get rid of the puddles, the first thing you got to do is patch up that sprinkler line that's leaking. And that sprinkler line is just like this great saphenous vein here that has leaky valves in it and is building up pressure. So we got to get rid of that pressure and that leaky line underneath, and then getting rid of the veins in the surface is like getting rid of the puddles. So those are the two steps to the process of treating venous insufficiency and varicose veins. The places that we can see leakage, The most common is the great saphenous vein, that main vein that runs from your groin all the way down to your ankle. And that's by far the most common place that we see leakage. People with venous insufficiency and varicose veins almost all have leakage in the great saphenous vein. However, we can also see leakage in other places. Next most common is the small saphenous vein, that vein behind your leg that goes down into your calf. And then there can also be what's called accessory saphenous veins. And that's these little branches that can come off in the thigh, come off of the great saphenous vein, for example, and then lead to varicose veins up in the thigh or in the outside of the thigh. And then we can also have leakage in these perforator veins, which are the little veins that can come from the skin or go from the skin to the muscle. They can leak. And then the last thing is something called neovascularity. And that's a word that means new blood vessel. And that's something we'll see in people that have had a previous vein stripping, for example. One of the problems with the old-fashioned vein stripping was that almost 20% of the time the vein would grow back. And when it would grow back, it wouldn't have any valves in it at all, so you actually could end up worse than you started. And that new vein that grows back is called neovascularity. So if you've had a previous vein stripping, that's something we need to look for and may have to treat. So how do we close down these leaky connections or that leaky great saphenous vein? As I mentioned earlier, we used to do vein strippings years ago. We don't do that anymore. It's not a very good operation. As I mentioned, up to 20% of the time, the vein can grow back to some degree. So it doesn't work very well. There can be wound healing problems. And again, it just is not a very good operation compared to more modern methods that we can use to get rid of those veins. And these are the different ways that we can treat those leaky veins now. The most common way is using heat, and that's something called thermal ablation. Thermal means heat, ablation means to destroy. So we can use heat to destroy those leaky veins, that great saphenous vein. And there's two different ways we can generate that heat. One is using a laser fiber, and the second way is something called radio frequency ablation, or RFA, and that's in essence using electricity to generate the heat. The second thing that we can do is something called mechanical ablation, and that's a procedure where instead of using heat, we use some sort of mechanical device, and I'll explain this a little more in a few minutes, but mechanically we destroy the vein and get rid of it that way. And then there's another method where we use a glue type of material to put inside the vein, and it glues the vein closed. And then the last one is something called foam, and that's a material that chemically burns the vein and gets rid of it that way. And I'll explain these all in a little more detail now. Using the laser or the radio frequency ablation, or RFA catheter, as I said, that's the most common thing that we use now to get rid of these leaky veins. These have both been around for many, many years. They're tried and true. The results are very good. They're pretty much equal in success rates between the two. Here you can see a picture of a laser fiber. In this next picture here, that's a picture of the radio frequency fiber. This metal end, which is about 3 inches long, is where the electricity is generated that then heats up the vein and kills it. This is a picture here showing the mechanical ablation, and this is a catheter that goes inside the vein, and we thread it up to the inside the vein just like the laser fiber. But instead of heating the vein up, the little tip of this catheter spins around really fast, and then we inject a little bit of medicine into the vein, and the combination of those two things kills the vein. What's nice about this technique is that we don't have to inject any numbing medicine. With the laser fiber or the radio frequency fiber, because we're heating the vein up, we have to inject numbing medicine into your leg to deaden it around the vein. If we didn't, you'd feel the heat of that catheter. With this technique here, because we're not heating anything up, we don't have to inject any numbing medicine. So it saves you about 4 or 5 shots that we have to give you down your leg to deaden it. Both of these techniques work very, very well. The next, or the newest method is using glue. This is a super glue type of a material called cyanoacrylate, but it is it's very specialized. It's not just super glue out of the container. It's a very specialized glue that stays very flexible. It requires very, very tiny amounts in the vein to glue this closed. Using glue to close veins has been around for a long, long time. We've used it for brain aneurysms and other things for many years. It's just more recent that the technique and the catheters have been adjusted to be able to use this in the legs. It's been around for about 5 or 6 years, and has just recently been starting to be approved by some of the insurance companies in the last couple of years. This technique works very, very well. Like the mechanical ablation technique, because we're not heating the vein up, we don't have to inject any numbing medicine. So that's nice. You don't have to get all the shots. And what's also nice about the glue is that you don't have to wear support stockings after the procedure. With the laser procedure or the radiofrequency procedure or the mechanical procedure, because we're damaging the vein and allowing the body to have to heal that and get rid of that vein, there is a healing time that takes place. And during that healing, we need to have pressure on the process to happen. And because of that, we have you wear support stockings after the procedure for about a week. With the glue procedure, there's really no healing that has to take place. The glue is in, and just like super glue, within a few minutes or 30 seconds, the glue is dry and the technique is done. So there really is no healing that has to take place from a healing or a vein standpoint. So because of that, we don't have to wear support stockings after the glue procedure. So that's very nice. So that's the advantage of the glue procedure. The disadvantage is that we are putting in a glue into your body, and that glue stays there the rest of your life. So it is a little bit of a foreign material that stays with you forever. It doesn't take very much. It's about 1/5 of a teaspoon that we use to glue off the whole vein. So it's literally just a few drops, but it is something that stays in you, again, the rest of your life. With the other procedures, the vein dies and disappears, your body absorbs it, and then it's gone. So there is nothing that remains in you forever. The foam that we use to close off the veins is the last method, and this is a chemical that we use to put inside the vein. The chemical burns the vein, kills it, and gets rid of it that way. And this works very, very well also. And there's different times that we use this compared to the other procedures. All of the procedures, depending, or I should say, regardless of what technique we're using, are all done in the same way. And what the procedure involves is first putting in an IV catheter into the vein. So if we're treating the great saphenous vein in this drawing, for example, we would put an IV catheter in down by the knee, and then through that IV catheter, we thread the catheter that we're using for whatever procedure up to your groin, up to where those valves are leaking. And then once the catheter is positioned correctly, then we do whatever we're going to do with the catheter, be it heat it up, or inject the glue, or spin the catheter around like the mechanical procedure. So we have the catheter do whatever it's going to do. We pull the catheter back down the vein, and as we're pulling it out, it treats the vein, and then the end result is that that vein is closed off and gone. As I said, in the laser procedure and the mechanical procedure or the radiofrequency procedure, that vein actually dies and disappears, and it's gone. With the glue procedure, the vein is sealed off and no longer having any blood flow through it. But again, as shown here, the end result is that there's no blood going back through that vein. So now everyone wonders, well, how's the blood getting up my leg when you just closed off that main skin vein? Well, remember, blood wasn't going down that vein anyways, because the valves were leaking. The blood was going down your leg instead of up. So getting rid of that vein actually helps your circulation. It doesn't hurt it. Because what was happening before we treated that vein as the blood was going up the deep veins and then back down the great saphenous vein, leaking back down into your leg, having to work its way into the deep veins, works its way back up, leaks back down into the deep veins, goes back up, half of it falls back down. So all day long you get this cycling of blood in your leg that never really leaves. That's why your leg feels heavy and achy and throbby by the end of the day, because all of the blood isn't leaving your leg like it's supposed to and going back up to the heart. So again, getting rid of that vein actually helps the circulation, because now all the blood that's going up the deep veins can go back up to the heart like it's supposed to. The other thing that people wonder about is that's the vein that's used for heart bypass surgery or leg bypass surgery, and what if I need one of those one day? Well, a couple things to address that. One is that for the great saphenous vein, we typically only have to treat it down to the knee. It's pretty uncommon for the vein below the knee to be leaking. And if it's not leaking, we leave it alone. So you have the great saphenous vein from your knee to your ankle, which still leaves some vein there for a heart bypass if they need it. The other thing is, as I showed earlier, when that vein is leaking, it gets all stretched out. Normally that vein is about, 1/4 to 3/8 to maybe a 1/2 inch in diameter. We'll see people that vein will stretch out up to 1 inch in diameter. You can imagine how much blood is leaking down that big vein. Could be as big as a garden hose all day long if there's no valves working in it. But the other thing is, when that vein gets all stretched out like that, it often can't be used for a bypass anyways. So once the vein is all stretched out and ruined, it's not any good even if it was there. So there's really no long-term detriment or risk or problem in treating and getting rid of those leaking veins. When we do the process, it can take many steps depending how many veins we need to treat. As I mentioned earlier, when we are doing the procedures, if we have to inject lidocaine or numbing medicine into those veins, we're sometimes limited by how much we can inject at one time if we're treating those veins, so we sometimes have to break those up and treat one leg one day and one leg another day. We're sometimes limited again by how much glue we can use at one time. So there's limitations there as to how many steps it may take for the treatments. I mentioned earlier there's 2 steps to the overall treatment plan. The first step is to get rid of that leaky vein, seal off that leaky sprinkler line, if you will. The second step then is to treat the veins in the skin. There's really 2 main ways that we do that. For the small spider veins that we see here, we do something called sclerotherapy or vein injections. Most people have heard of that. However, vein injections don't work very well on the big bulging veins like we see here, on the big varicose veins. What can happen is with these big bulging veins that are pushing out against the skin, they're right under the skin. The skin becomes very thin there, and if we inject a high dose of medicine into a big bulging vein like that to kill it, which we can do, sometimes that medication will leak out of the vein and can end up staining the skin. So what can happen is the vein disappears. However, you've got this brown stain over the vein in the skin that looks like a brown line where the vein was. That doesn't look very good. And that can be permanent. So injecting the big bulging veins is not always a good idea. So the way that we treat the big bulging veins is with a procedure that's called a phlebectomy, which means vein removal. It's technically not a vein stripping, but it is a surgical removal. What we do is make little tiny incisions, about 1/8 of an inch long, along the bulging vein. We put a little hook instrument under the skin, tease the vein out, and pull that vein out through that little tiny incision. It sounds kind of bad, but the leg is numb and deadened. You don't really feel it, and it works very, very well. Here's an example of a gentleman with these big bulging veins on the back of his calf. After the phlebectomy procedure, this is a couple of weeks later. You can't even hardly see the small incisions that we made to pull those veins out. We don't even put stitches in them. They're so small, they just scab over, heal up, and then go away. So at 6 months, if anything, you might see a few little freckles, but that's really about it. So it's very cosmetic from that standpoint. However, I don't mean to use the word cosmetic in that there's no pain relief in doing this. Getting rid of those big veins is far from cosmetic in that there can be a lot of relief, but it is very cosmetic in that it does not leave any scarring. I mentioned the sclerotherapy, or the vein injections that we do for the spider veins. For this part of the treatment plan, you come into the office for a 20-minute appointment, and then we use a very tiny needle, smaller than a diabetic needle, inject the medicine into the veins. The medicine flows out into the veins, kills the vein, and then over about 6 or 8 weeks, the vein disappears. Sometimes if they're very dense like this, we do have to go over them a couple of times, but eventually we do get rid of them. And as I mentioned here, this is the last step, if you will, in the treatment process. We close off the leaky veins first with the laser or the radiofrequency catheter or the glue. And then the next step is to remove any of the bulging veins. Sometimes we can do that with the laser procedure. If there's a lot of them to do, we quite often do it as a separate procedure. And then the last step is to come in for the sclerotherapy for the vein injections, for the spider veins. So that's, again, kind of the last step of the process. And here's an example of someone with a lot of spider veins on the inside of the calf. And after the series of injections, here you can see that they're all gone. Again, sometimes if there's a lot of them, we do have to go over them, but eventually we do get rid of them. And once they're gone, they're gone. Everyone wonders how painful the procedures are, and everybody's pretty apprehensive. As I mentioned earlier, the parts of the procedure that hurt are really two different things. One is putting in the IV catheter, which is really not any different than just getting an IV put in at the hospital. We do deaden the skin with a little numbing shot and then put the IV into the vein. People tolerate that very well. The next part of the procedure that stings is the numbing shots down the leg if we're doing the laser or the radiofrequency procedure. So for that procedure, we have to do 4 or 5, depending how long your leg is, maybe 6 numbing shots down the leg. And those do sting a little bit, just like the dentist putting numbing medicine into your mouth. It stings a little bit. We do offer you can take Valium ahead of time, which will make you a little relaxed and a little sleepy. We do have nitrous gas, just like the dentist uses also, and that also will help cut the edge a little bit. If you do use these medications, then you need somebody to take you home. If you don't, then you just come in and get the few shots, and after the procedure, walk out of here and drive yourself home. After the procedure, maybe a little stinging or pulling sensation, just Tylenol or Motrin though for pain. Rarely is it ever more painful than just needing Tylenol or Motrin. And most people are back to normal activity in 3 or 4 days. After the procedure, we have you keep your leg wrapped up with the dressings for 48 hours. We do want you up walking during that time. There's really no set restrictions other than the next day. We just want you to take it easy. No real heavy duty lifting. You can be up moving around, but we just ask that you don't do anything where you'd be straining and grunting. When you do that and strain like that and tighten your abdominal muscles, that forces blood back down into your leg, which theoretically could open that vein up the next day. So we just ask that you don't do any real heavy, strenuous lifting or straining the next day. But we do want you up walking. After the second day, you're going to take the dressings off, take the bandage off, and at that point you can do whatever you want. There's really no restrictions. And then I mentioned earlier, we do have you wear support stockings for a week after the procedures while the veins are healing. You don't have to wear them at night while you're sleeping, but wear them all day long. And the advantage of the glue procedure that's called the VenaSeal procedure is that we don't have to do any support stockings, and there's absolutely no restrictions because there's really no healing that has to take place. Once the vein is glued closed, it's closed. Risks of the procedure are fairly small. There is a risk of bruising. We sometimes see some bruising around the IV site in the leg. That's very common. That'll go away in a week or 2. Swelling is really very uncommon. We rarely see any swelling. If it is, we would want to know about that. Risk of blood clots is about 1 in 1,000. Every surgery has a risk of blood clots. The risk in this procedure is really not any higher just because we're working on the veins. And again, it's about 1 in 1,000. Everyone wonders, don't the veins all come back? The veins that we're treating do not come back. Once the veins are dead and they're gone and your body absorbs them, they're gone. And those veins are not going to come back. However, that's not to say that you may not develop new veins down the road. What we found is that about 20% of people will develop new leakage at some point down the road. It's a new vein leaking that wasn't leaking before, that's letting pressure out into the skin, and then we get more veins. So again, about 1 out of 5 people will get new leakage in the future. Because of that, you may need some touch-up sessions. We tend to do ultrasound exams every year to follow up on that, to make sure that there isn't any leakage that's coming back or any new veins forming. Insurance does cover this as long as it's being done for symptoms and not purely for cosmetic reasons. So as long as you have any pain, aching, swelling, burning, or throbbing, or itching, or ulcers, or bleeding, it is something that insurance does cover. If not, if it's purely cosmetic, then insurance does not cover that. Most insurance companies do require a trial of conservative therapy, which involves elevation, stockings, exercise, rest. So we do need to do all that before we resort to surgical treatment. And a lot of the plans will cover the sclerotherapy as long as that's being done for symptoms and part of the treatment plan. My experience here treating veins, I've been doing this for almost 25 years now. I was one of the first practices in Michigan to have a laser and do the endoluminal laser procedure back in 2002. So far, we've done well over 7,000 of these procedures on over 3,000 patients. We've had 4 patients with a blood clot, so well less than 1 in 1,000, and those were all very minor and resolved. And in our patients, 91% of patients are back to normal activity in 3 or 4 days. And at this time, I'd be happy to answer any questions.